where we should really put everything that we've learned kind of together. So we've talked about a lot of different diagnoses, right? But then things happen where people have trouble getting full range of motion back. And that's one of the most challenging things, and where we have the most potential to make the biggest impact, is we're not going to just keep giving the patient strengthening exercises thinking they're going to get better, right? And that's what happens a lot of the times is people think, well, if they just get stronger, they'll be able to move better, and that will never ever happen because it's usually a soft tissue length problem why people can't move, right? So strengthening them, unless it's a nerve pathology, you know, strengthening them will not make a difference because when people are stiff, they have problems with passive range of motion, right? So what do you think are some of the reasons people get stiff? Not anatomy-wise, but big picture things, like what happens?
Fracture from mobilization.
They might be immobilized for a long period of time, like maybe they had a non-union, so they had to be splinted or casted for a long period of time. Maybe they have poor bones, so they didn't heal as quickly, so they had to be, their immobilization time was great. Yeah. Extrinsic healing, because maybe they had a traumatic aggressive surgeon, or maybe they're just a big scar maker. Some people make bigger scar than other people. So it could be just extrinsic healing and that big scar that happens.
Spasticity?
So it could be from spasticity, but in the orthopedic thing, that's not going to be an issue, right? So with orthopedic conditions, we don't talk about tone, right? Because that's central nervous. But people might get stiff because of spasticity, where a tone holds them in a flexion synergy pattern for a prolonged time, and their joints get stiff. So even if you Botoxed or did something, you wouldn't be able to do full range of motion.
Could guarding lead to stiffness, like the act of them just not moving?
Yeah, like fear. People are scared and they don't want to, it hurts. And our natural response when something hurts is to stop it, right? So guarding, fear, pain, all of those things promote stiffness because people don't want to let it move the full range of motion. And, you know, we've already learned in neuro how many sensory receptors we have in our distal extremity, right? So with injury to this area comes a lot of pain, more than if you cut yourself on your thigh or somewhere else where you don't have so many sensory receptors. A lot of pain with upper extremity injuries. What else? Edema. The more edema, the more scar, the more scar, the more stiffness, right? So people that are hugely swollen get hugely stiff frequently. Yeah. What else? That I've kind of beat to death in this class a little bit. Incorrect management, right? Maybe they were casted for this for 6 weeks, and then they went to PT for 2 months, and they didn't get any better, so then they got referred to a hand surgeon, and oh, the fracture's not aligned, they have to have surgery. Then they have surgery where they're immobilized again, right? And then they go to therapy, and by the time you get them, they're hugely stiff because now it's this much longer process than should have occurred. What else? What about incorrect casting? You know, cast is too long. People can't move their fingers. It's on for 6 to 8 weeks to get out of the cast. Stiff fingers, right? So incorrect casting. Some people don't want to get better. It's true. Some people don't want to get better. They may be coming to therapy, but they may have secondary gains when they want to be off work because they don't want to be too good too quick, right? Because they want to be off work the whole summer because they don't have a babysitter for their kids, and that way they don't have to pay for childcare, right? So if I can stretch this baby out, right, to get through the end of August, I'll be good. And then it's a work comp injury, so I'm being paid while I'm not working, right? But those things happen. So lots of reasons why stiffness occurs. That would be like an underlying thing. Sympathetic changes. right? Sometimes people get sympathetic involvement following a trauma, and that creates all these other problems that then create stiffness. More swelling, more pain, more fear, maybe an underlying psychosocial issue with the patient. You know, lots of things going on there. And some people are more hardy than other people. Some people, you know, just do what you gotta do, right? And they're fine with it. And some people, as soon as you start to touch them, it hurts and they want to, they can't tolerate the pain at all. So, lots of things. Insurance issues, right? People couldn't afford to go to therapy, and now it's stiff. They went back to the doctor's like, you have to go to therapy. Well, now you're behind the 8 ball, right? So we're gonna break these down, and there's some pictures in here, but, you know, prolonged. Sometimes people don't have surgery, but that means they're immobilized longer. The cast could be incorrect, or they take longer to heal because of those factors that we discussed, diabetes, bad fracture that was comminuted and is going to take a longer time to heal. Oh, I forgot to mention, I think the wound course was great. Anyone want to have any feedback for those of you that went, that want to share your experience? Anything? 2 students won free things. Like Andrew, you won something.
Yeah.
What did you win? Because I kind of want to watch it.
It's like anatomy of the hand and shoulder or something like that.
Was it
Something
CD?
of the hand and shoulder.
A CD?
Yeah.
Anatomy. And then Danielle. Oh, you won something, right?
Yeah, it was the same thing, both of them.
Oh, the thumb. That would be a good one. Yeah. Yeah. Do you want to share anything about what it was like, or? It was.
Well,
I was gonna say, I just thought it was kind of cool that like the things we had learned in here, like do trans, and they just referenced things that I wouldn't have known. If I
You knew
didn't
what they
have
were
this
talking
course.
about.
So it felt kind of interesting to know what they were talking about. It felt
Yeah.
kinda cool.
And good, right?
Yeah, and then it was interesting to hear like a doctor's perspective on what they're doing to work on it, so that way as a therapist, when those clients come on to us, we'll actually know the procedures and what they kind of entailed before coming to us. So it's just kind of.
And there was some
connecting with
variability in what they all do too, right?
Yeah.
Not, they
Yeah.
all didn't do the same thing for everything.
Yeah, so it's kind of interesting to see how it all connects, I guess.
Yeah.
Which was interesting.
Anyone else want to share?
I thought it was interesting that Dr. Judson was sitting in front of us and he talked the whole time, but
I know.
he was,
And he was sitting behind me, and I almost went, shh. But that would be good.
but he was talking with other surgeons and they were referencing articles in the journal Hand Therapy and talking about different procedures, so I thought it was kind of interesting.
Yeah, and they don't really have much opportunity for that. You know, they're either in the OR where they're not with other docs, or they're in their own practice where they're not with other docs. So they don't have much opportunity to share, you know? It'd be like if you worked solo on your own and didn't work with any other OTs, and then you got on a Saturday event and you're like, oh, I have this patient that didn't, you know, like, you know, so, I wanted to, shh, go to the hall, you know, but I wasn't gonna do that, you know? Yeah.
I didn't tell him to be quiet.
Yeah, I wouldn't recommend that. But, yeah, so I thought it was a good course. They were done on time, so it was good. All right, so, traumatic injury. And we saw some pictures like this on Saturday, right? When you have multiple things involved at the same time, huge opportunity for stiffness. Now, we don't see these patients, right? They go to the doctors and they fix what they can, amputate what they need to, reconstruct what they need to, and then we see them, right? Sympathetic involvement. What do you see here that says sympathetic involvement? Shiny, really shiny, swollen. Yeah. Oh, these are hooks.
Yeah.
Hooks, because she has significant stiffness, right? So, she's using a splint to pull her fingers into flexion, not at this time. But this is her fist. Did I show you her hand before? She had an LRTI. She was a postal worker, and she had significant osteoarthritis bilaterally, which was genetic, right? The osteoarthritis is genetic, but due to the type of work she did, and she had a walking route for being a mail carrier, so she would stack the mail, like she would prep it with all these houses, and then she would hold, one here, one here, one here, and one here, and then drop them all, and then restack mail in all of her fingers. So she did this constant pinch all day long with her hand. So remember how many pounds of force here, and how many pounds of force here, right? So she developed horrific thumb pain that she couldn't work, so she had an LRTI. The surgeon that did her LRTI is the one that had the wandering eye with all the kids, remember? So he did mostly knees and hips, but he loved doing hands, so he would keep doing hands every once in a while, but he had a really traumatic, his patients had a lot of edema when I saw them. They had a lot of stiffness because he was used to working with bigger joints and then went to working, you see what I'm saying? So, sympathetic involvement. Patient characteristics can be a lot of things. Outside responsibilities, If I threw a hand injury into my life right now, I don't know how I would have time to do my home program, right? So people are single parents, they're working full time, it's hard to get everything in, hard to even attend therapy. And then some people are just kind of, we call them knuckleheads, they don't do what they're supposed to do, right? And then they get stiff. Delay inappropriate treatment, which we've talked a lot about that in this class. Insurance, some people only get so many visits authorized, some people don't have splints authorized that they might need, huge co-pays, huge deductibles, all of those things, and some people might have a different deductible for splint coverage than for their therapy, just all kinds of things that are present in the environment now that didn't used to be. So all kinds of things can cause stiffness. What we have to do is figure out what is causing the stiffness, right? What is the root? What do I have to correct? And you have to know the anatomy to figure it out, right? So what is one of the first things, if a patient's not moving, what is the first thing that we should check? Passive motion versus active, right? Because if they have good passive motion, is it a stiffness problem? It's not a stiffness problem. What's the problem? Strength, or in the hand, likely tendon glide. The tendon's not gliding. In other areas like the shoulder, strength. We don't usually have gliding issues in the shoulder, but in the hand, when something is not moving and they have full passive, it's usually a tendon gliding or a tendon problem, or unless they had nerve dysfunction. But tendon gliding is a huge problem in the hand because our tendons have to glide through all of these structures to create finger motion, and that's usually the culprit. So I am going to check. Is it a joint problem, or is it a strength problem, or is it a tendon gliding problem, right? And if it's a tendon gliding problem or a strength problem, will a dynamic splint or passive range of motion make a difference? No. Because passive range of motion works on stiffness, on passive joint. It works on the joint. Splinting works on the joint. It's not going to increase strength, and it's not going to increase tendon glide. So if bad active, bad passive, stiffness, and it could be a joint problem. Bad active, good passive, it's not a stiffness problem. It's either a strength problem or a tendon gliding problem. where you don't need to do passive motion. I mean, you don't want them to get stiff, but passive range of motion is not going to fix their problem. So I get lots of calls from people, from therapists that say, I have a patient who's not moving well, I'm thinking about doing dynamic splinting. And I get out there and they have full passive motion. They don't need dynamic splinting. They have a strength problem or likely a tendon gliding problem. And a dynamic splint will not fix that. So you have to, so if you call me and you want me to help you splint a patient, I will help you, but I'm gonna ask you, do they have full passive range of motion? And you should know the answer to that, because you should have already checked that before you call me. Okay? Check active motion, check passive motion. All right? So if it's a stiffness problem, it could be a lot of factors, right? It could be the joint. They could have had an interarticular fracture, and now they don't have good alignment, right? Or they have malunion, or maybe the fracture was so comminuted and bad that it couldn't be repaired to a normal joint. So they have a bony block. So you know the description of end-feel. Have you learned that in other classes, or have we talked about it here? In functional assessment. So end-feel kind of describes how bad the stiffness is. If it feels soft and springy, which is hard for you to know because you haven't felt a lot of stiff joints, right? But once you start feeling some stiff joints, you'll gain some perspective and experience and be able to describe that in a better way. So if it feels soft and springy, that means not a ton of stiffness, and there's a good potential to get that moving. If you feel it and it's hard, it could be a bony block and the joint doesn't have potential to move. So in that case, I might need to have ask the doctor a question. What do you think the potential is for this joint to move? Or do you think that this joint has the potential for full range of motion? And the doctor should be able to tell you that because they see the x-rays and they know what's happening there. So evaluate the end field to see what the potential is. Is it a bony block or is it some kind of soft tissue situation that is keeping the joint from moving? I will tell you most likely in the hand, it's usually a soft tissue length problem. People didn't lengthen their soft tissue for a long period of time and it adaptively shortens. Another thing to check is, are they intrinsically tight? So when I'm checking to see if they're intrinsically tight, what muscle am I checking? The lumbricals, right? And remember, the lumbricals go volarly on the MP joints, dorsally on the PIP joints. So to stretch it, I hyperextend the MP and try to flex the PIP. So the way to check to see if it's tight is if the PIP can't move as well when the MP is up or hyperextended. So if I come down here and I can bend the PIP, great, right? But I come up and I can't, I know I have intrinsic tightness. And that could be why your patient's having functional problems. Could be intrinsic tightness. They could have extrinsic tightness. What does extrinsic mean? The muscles all across the wrist, if they're extrinsic. So the position of the wrist will influence how the fingers work, right? So maybe they can straighten their fingers when they flex the wrist, or they can extend the wrist and make their fingers bend, but they can't do the opposite, right? So checking for extrinsic tightness of the extensors, right? I would flex the wrist and see if they can make a fist, or flex the fingers and see how far the wrist flexes. Everything has to elongate at once. Extrinsic tightness of the flexors, they can't do this. Extend their wrist and their fingers at the same time. For weight bearing, or weight receiving, or whichever, push-ups, yoga, any of those things. This would be probably a more uncommon thing, but sometimes if people can't get good full flexion, it's tightness of the oblique retinacular ligament, ORL, oblique retinacular ligament. It's also called Landsmeer's ligament. It goes the same path as the lumbricals, but more distal. So it goes volar at the PIP, dorsal at the DIP. So the way you stretch it is doing a blocking exercise for the index finger this way would be to stretch the oblique retinacular ligament or the ORL. That's the way you would stretch it.
Can you say it goes volar at the?
Goes volar at the PIP, dorsal at the DIP. Just like lumbrical, volar at the MP, dorsal at the PIP. A big thing is scar. If it's white, it's tight. And I remember when I was a level 2 student, my fieldwork supervisor told me that, and I will never forget it. I still say it. If it's white, it's tight. And that's people with darker skin too. It blanches when something is restricting the movement. So watch the scar. Look at the scar. Look for blanching. Look for puckering. So sometimes when you try to move, say I had a dorsal scar on my finger, and if I was trying to extend and it puckered, I know that my scar is stuck to my extensor tendon, and that's why I can't straighten all the way. If I can passively straighten it, I know it's not a stiffness problem, it's a gliding problem. But scar can limit glide, scar can limit movement, even just external scar. If you have a volar wrist scar, you may not be able to extend your wrist all the way because the skin is limiting you from extending. So it could be a scar issue. But tendon glide is huge. And you guys all understand this, right? If the patient has full passive but bad active, the tendon is not gliding or it's not attached, it's not working, something is wrong. So you have to compare the active versus the passive. It could be something nerve-wise, like a claw deformity is present, right? And you think they have PIP flexion contractures, but really it's an underlying ulnar nerve impairment that created this pattern. It's nerve, right? And then, you know, a lot of times you have to go with your gut. Does something else just seem wrong? Because sometimes people have a trauma, like a distal radius fracture. They go to the ER, that gets picked up in a heartbeat from the x-ray. Very easy to see with a cheap diagnostic. They get sent to a surgeon, a distal radius is fixed, but then you see them and you're like, something just doesn't seem right. Hopefully they don't have the plate over their dorsal ulnar nerve, right? But it might be some kind of undiagnosed ligament injury in the wrist, or a TFCC tear. Something else might be going on that may be keeping the patient from improving in their range of motion. That didn't get diagnosed because it's not picked up. Any soft tissue injury will not be picked up in an x-ray. So you need further diagnostics done. So if we figure out what's wrong, right, then we have to figure out, well, what the heck am I going to do about it, right? What am I going to do? So biggest thing from the start is getting a handle on the edema. That is number one thing that you want to do with all of your patients is get the edema under control. And one way, remember that we get the edema under control is getting them moving. Because our lymphatics don't have a heart, right? So the only way that I can get edema out of my hand is through elevation and the active muscle pump that occurs in my upper quadrant, right? Elevation and range of motion. And then I also need to control the tissue pressure externally. So I need to do something, Coban, isotoner glove, tuba grip, lymphedema wrap, gel sleeve, something to girdle, something to get around the extremity and get the edema out. So range of motion, elevation, something to increase the tissue pressure from the outside. And some people will say, well, they have a wound, right? They have a wound, I don't wanna put, Cobian around it, because they have a wound. If someone has a wound and they are hugely swollen, what will happen to that wound? It could split because they're hugely swollen, but where is the edema gonna go? Or where's the fluid gonna go? Out the wound, right? So what will happen to the skin around the perimeter of the wound? It will macerate. And then what will happen to the size of your wound? It will get bigger, right? So you can't not control the edema just because they have a wound, right? Do I want to put Coban right over top of a wound? No, right? We're going to use the appropriate dressing based on what's happening with the wound. If it's too wet, we need a dressing that will absorb the wound, absorb the fluid, and something that will keep the dressing from sticking. Remember, we don't like those shiny dressings. No shiny dressings, those non-adherent shiny dressings. None of those, they won't absorb, right? And then we'll put the Coban around the outside of the dressing. That will still increase the tissue pressure from the outside and get them moving, right? Get the edema under control. Manual lymph drainage. They can work in their axillary area, right? To help clear the edema from their upper extremity. Okay, here is the biggie take-home message for today, okay? When people have stiffness, they tend to move what's easy and not move what's hard, right? So when we look at that, remember we talked about the appropriate thing of fisting. Like when we make a fist, what's the first muscle that constricts? Wrist extensors. So look at your patient and do they have good wrist extension? Right? If they don't have good wrist extension, you've got to work on that first. Right? If they can't get to neutral because of tone or because of radial nerve pathology or stiffness because they were put in a cotton motor's position because they have an 84-year-old orthopedic surgeon that, something like that, you have to get their wrist in extension. If you can't get their wrist in extension, they will never have a good fist. Wrist first, wrist extension. Then what happens next for the pattern of fisting? Do you remember? EDC, the MPs extend, right? So our radial nerve pathology people, are they going to have a good fist? No, because I got two areas right there that the muscles aren't working, and they're the first ones of fisting. Wrist extension, EDC. And then what happens after the MPs extend? And I know you're going to lose sleep thinking about, okay, what is the correct pattern of fisting, You get, both of your IPs start to flex and you get a hook fist, okay? So if your patient cannot make a hook fist, will they ever get a full fist? No, okay? And then what happens after the hook? They come down into empty flexion, right? So the first thing, wrist extension. And this is what happens when patients are really trying to work hard to get a fist, and you will see it over and over again. They'll be fisting and they'll be trying to pull with their fingers really hard, and their wrist keeps flexing, and they're trying to fist like this. Will they ever get it? No. Show them, like, look, you're flexing your wrist. You have to keep your wrist in extension, or if they can't hold it, have them hold in extension with their other hand. And have them work on fisting like this. It's the best way to decrease extrinsic tightness, right? It's their best chance to get it. Look at what it does to the tendons. If I move my tendons into extension, I already created glide because I extended my wrist. And it gives my fingers a better mechanical advantage to flex. So if they're having trouble, put their wrist as far back in extension as you can get it and work on finger flexion. If you do it yourself manually, your fingers almost water flex, right? Because I can't extend mine all the way because of extrinsic tightness, right? Push the wrist all the way back. Wrist extension, wrist extension, wrist extension. That has to be first. Then MP extension, then the hook. But what people do, oh, I had it up here. I gave you all the answers and I was asking you. But what people do is they develop, and this is my lady with the LRTI. You can see it's an LRTI because look, she has her incision here. She has her hash marks where they harvested her flexor carpi radialis tendon and probably palmaris longus, right? Palmaris longus to reconstruct the CMC. And she has sympathetic involvement, right? But what she does when she fists is she flexes her MPs because that's the easiest thing to bend. And then she tries to pull in with the fingers. So do it yourself. Flex your MPs all the way down, and try to pull your fingers in. See how much harder that is? She's never gonna get it. Never. And you can see her here. She is not hooking before she fists. You have to hook. You have to get a good hook. Here's another patient. This patient had a P1 fracture. Here you can see these were from her, I think she had percutaneous pins and she was scarred there. And it's pretty raised for just a pin scar. Can you see that right there? So she's a big scar maker. So what do you think about, she's trying to hook right there. How do you think her hook looks? She's not hooking very well, is she? Her index finger and long finger are hooking, right? But she's trying really hard and her MPs are starting to bend. She cannot hook. She's never gonna get the fist. You don't get the hook first, you gotta get the hook. Okay? So how can I get a patient to hook if they can't hook? What are we gonna do? We got a patient, level 2 field work, she comes in, this is what she looks like, except for this little hook on her fingernail. All right? What am I gonna do? I could do blocking exercises, and that's actually which one the next slides is, to put the position of the finger to make it more optimal to move. Just like wrist extension will help your fingers move, if I passively hold the finger, the MP and extension, I'll have a greater likelihood that my PIP will flex, unless there's what? No. Intrinsic tightness. If her lumbricals are stiff, will that help her? I mean, you'll have to stretch it out, but it's going to be harder, right? So a lot of people that have trouble hooking, what do you think their root of their problem might be? Intrinsic tightness, right? And if they can't hook, they'll never get the fist because you got to hook before you fist. Okay? All right. So what am I going to do with her? She just arrived. She's a single mom with 2 kids and works full time. And her kids were like 2 and 4, so not an easy age. They were little. So there's kind of a cue that I think splinting would be appropriate, right? How would I splint her? She needs to make a hook, right?
So would you want her, which one to extend?
I would want to extend the MP joints and pull the PIP down, right? So I don't want to just pull all the fingers down together, right? All 3 joints. I need to stretch the lumbrical. So I need to hold the MP up and pull down on the PIP, right? If I just pull, and this is why I love this picture, if I just pull on the distal phalanx at the tip of the nail, what will likely happen if the intrinsic muscle is super tight? look at the small finger.
Good, Drew.
The DIP is bending like crazy, and that PIP still will not bend. And look, she wants to flex these MPs because her lumbricals are tight, right? So you want to do something like a loop. Take a loop and put it over just to bend just the PIP and get that MP all the way up and splint down this way. But do you see why you don't want to pull it from the end? Because I'm just going to get a really flexible DIP joint. And that lumbrical is holding its own, it's still not going to let me bend it. Because what do you think has more resistance? The lumbrical, which is like a worm-like muscle, or my little terminal extensor tendon? Right? Those lumbricals are strong. They are strong. So you have to do something. So splinting. Now what are my other choices? What kind of splint should I make? Dynamic or static progressive? Why?
You slowly want to increase to get her in order to,
So what do you think the difference would be, dynamic or static progressive? When do you choose one or the other?
Well, she doesn't have a problem. I mean, it's a block, so the dynamic isn't really gonna help her, but the static progressive is gonna apply the load of the force over a long time to.
The dynamic still could help her. The difference when you're deciding between the two is the length of the time of stiffness. The longer the stiffness, static progressive. The more recent the stiffness, dynamic. Rubber band traction is dynamic. Static progressive would use like a nylon cord that you can't come out of. So that's what, so if this was like day 2 and this is what I had and she just had surgery, just got her pins out, she's pretty fresh, dynamic would probably work fine. Static progressive is more forceful. So I want to make the splint, I could probably make it hand-based, right? Block her at the PIP, realizing that my PIP height is going to be different between the ring finger and the small finger, right? So I can't make just one line, I have to stair step it, right? So that it comes to here on both fingers and bring a loop down to pull down the PIP joints. Okay? So dynamic or static, so those are the things you have to kind of figure out. But one way is to change the position of the joint to make it more likely that you'll bend. So we use the example, if I can't get her to hook, right, I'm gonna hold her up and I'm gonna work on blocking here. But conversely, if I couldn't get the PIP to straighten, I'm gonna flex her PIP and work on straightening. It puts my joint in a better, or my tendon in a better mechanical advantage. Do you see why that makes sense? Do it to yourself and feel where it might be harder with your small finger because it's not as forceful, but do it with index finger. And then put it in the MP in flexion and you can see how much easier it is for you to extend your PIP. So put the joint in a position of a better mechanical advantage. If I flex the MP, I already create a tendon glide of the extensor. And I can extend. I feel like people aren't getting this because you're looking at me with puzzled expressions. Do you get it? Do you want me to go over it some more? No? So if we look at this string, right? And if I'm up here all the way to the top, okay? This is going to be a little bit of a slack, right? Harder for me to extend. If I bend the MP, it's going to take up some of that slack and I'll have a better opportunity to extend because I took up some of the slack by flexing the MP. The same thing with my glide for my flexors. When I'm down, my tendons all wiggle up in there. I don't have a good tendon glide to pull for flexion but when I bring it up, I take up some of the slack of the flexor tendon, so my tendon has a better mechanical advantage to flex. Do we get it? Okay. All right. Okay, managing scar. if we have scar, what kinds of things are we gonna do to influence it? Saying, we'll use this example on the dorsal of my hand. I have full passive extension, right? So I don't have stiffness. I have a gliding problem. But when I try to extend my fingers, I'm stuck like this because I can't bring my ring finger all the way up. But I can passively bring it up, right? And I watch the skin and I notice my skin puckers when I'm trying to pull that ring finger up. So I know my EDC tendon is stuck to that skin, to the scar. What can I do?
Can't you do like, tissue manipulation? To, like,
I can do manipulation, I can do vigorous massage or mobilization, so we don't use the word massage, mobilize that skin to get it moving, right? What else? Did you say something?
I said scar tissue mobilization. Are we correct when you say soft tissue mobilization?
Oh yeah, soft tissue, you can call it either soft tissue mobilization or scar mobilization. Just, and you wanna not do this, right? I am not mobilizing anything right here. I might be doing a little bit of desensitization, right? You want to get the skin moving when you're doing scar mobilization. You want to get the skin moving. Pressure, pressure, pressure. Right, Susie?
Right.
Yeah.
Well, like silicone, is that more for like the surface scar, but not really for the deep?
Well, a lot of times, it's right underneath the surface, and silicone is a thing that could help.
Even if it's like the limiting scar, it might not be like.
Yep. Yep.
You guys use ultrasound on scar tissue.
So you could use ultrasound. So will ultrasound alone impact scar? If I just have my patient, I sound them, and I say, goodbye, I'll see you next time. Am I doing anything? No. What do I have to do after the ultrasound? Scar mobilization. Can I take a call after the ultrasound before the scar mobilization? No, it only lasts 5 minutes after the sound. If you take a call, you missed your window, you're billing them for nothing, right? All the sound will do is heat the tissue. If I heat the tissue and then say, bye, see you next week, I'm doing nothing, right? If I heat the tissue and go to the bathroom, or take a call, or have a conversation, oh, so-and-so just came in, let me go talk to them real quick, I'll be right back. No, you can't do that. You gotta write even at the time so I might even flex the fingers while I'm scarring. Because maybe I have a lag and I can't flex all the way. 2, I might flex the finger, because it's stuck in scar, while I'm sounding. And then after, I'm gonna have them try to extend and I'm gonna mobilize that scar right after the sound is done. Do I use thermal ultrasound or non-thermal ultrasound? Thermal. So what temperature do I want to get the tissue up to at least to
4
be
degrees.
considered thermal?
4.
4 Celsius. What about if a patient has say I had a metacarpal fracture of my ring finger and I have a ORIF. They have a metal plate in there. Can I still sound?
No.
You can. But for NBCOT, you can't. All right? You can, but I'm going to take that into consideration. Because what will absorb sound more, the bone or metal? Right. What if they're, I hate to say this, but what if they're a bariatric patient and they're hugely obese, right? And sometimes this can be a big poofy area, right? Will that impact my sound? Mm-hmm. Because fat absorbs sound less than bone, and metal absorbs sound more than bone. So you want to think about all of those factors when you're figuring out your sound parameters and how quickly you move the sound head.
So would you move it slower and do it longer for somebody who's like more usually obese?
Yes. Mm-hmm. If they have metal, I'm moving it faster, right? And maybe we'll turn it down. And if my patient says it's hot, what do? Stop. But do I just lift the sound head up and stop? No. What will you do to your sound head? Destroy it, right? You need to turn the sound off because the sound will damage the crystal in the sound head and will ruin your ultrasound unit. Okay, so you can't just lift it up and say, she has pain, you know. Turn it off, turn it off, turn it off, turn it off. But get it off then, yeah? What if they say, I'm starting to feel it's getting pretty warm. Move it more, turn it down. So I'm going to talk to my patient and I'm going to let them know before I start what they should be looking for, right? Okay. All right, so I'm going to sound. I'm going to use, so here's my parameters, right? What about this? Could I use iontophoresis for that scar?
Sure.
With the one on the hand?
Well, we'll pretend now my scar's on the molar side, but yeah. Could I use iontophoresis for scar?
Yes.
Yeah. Yes. What medicine will I put on the patch?
Is it saline?
Saline. Do I just buy saline at Walgreens?
No.
No. You have to go to a compound pharmacy and get at least 4%. Saline from the store, I don't remember the exact, I need to look that up so that I know, because I always say that. I think it's like 0.4 or 0.7. Not enough concentration to do that. Can't use regular saline. What else could I use instead of saline? Potassium iodide. 10% concentration. I could use also ionto. When in the treatment session for this day would I put the ionto on? At the beginning or at the end? Why?
Because the medicine, because if you don't do it at the beginning, you'll just move the medicine.
Right. So if probably if I'm having a scar problem, I'm going to mobilize the scar. I'm going to be doing exercises in optimal positions, right? And that will push my medicine out where I put it in. So if I'm going to do iontophoresis, I want to do it at the very end of the visit. Would they want to go for a run right after? No. No. Same thing. Give your patient permission to take it easy for a couple of hours. Go watch TV, right? When do we ever hear that? You know, take a nap, right? Because they don't want to do a lot of vigorous exercise to get their overall body circulation up, which would make the medicine disperse out more quickly. Take it easy for a little bit.
And will the medicine just help with the breakdown, or is it?
The medicine has been shown to decrease scar adhesions, to really actually, you know,
Have you used ontophoresis at all?
phonophoresis.
What is phonophoresis?
Phonophoresis is where you take a medicine and push it through the skin with ultrasound, right? So I went to a course once, so I know I don't use phonophoresis. Because remember I talked about if you were ever concerned about if your ultrasound was working, you could take your ultrasound head, put tape around it, right? Put a little bit of gel, right? And then put water on it. Like the tape makes a cup around the end of your ultrasound head, and then turn your ultrasound unit on, and the water should bubble as the sound escapes through the water, right? You'll see bubbling. So I went to a course, and they did that with an ultrasound head, and they used the medicines that they used for phonophoresis and put it on the sound head, and then put water on top, and no bubbling happened.
So they're getting through the skin, basically.
Right. And did you find any research on
It
phonophoresis?
just popped up when I was doing my research on carpal tunnel syndrome.
Yeah.
And I eliminated studies that use just phonophoresis.
Right.
So I just had to ask. 'Cause
Yeah. So there's not research to support its use. A lot of PTs still do it. Do you see it at your clinic, Dave?
No. I mean, it's easier to do that. You put it on them, let them sit there for a few minutes, and it's done. You don't have to sit there and
Right.
on
So
them for 8 minutes.
time. But this, how much do you think these cost? Did we talk about this already? $12, right? How much do you think you get reimbursed for a iontophoresis? No, probably like 15. So when you buy the patch for 12, and the patient has to get the medicine, your time to put it on, is it a profitable modality?
If they have increased outcomes, it could be.
Right, I mean, our goal is to make the patient better, right? And other things that we do, we can get more reimbursement. But this is not gonna make you money, right? And the reason why it doesn't make you money is there's not a lot of good research out there to show it works. If someone did a study and showed that this would fix everything, right? But when I'm doing this for SCAR, is this all I'm gonna do? No way, right? Could I do a randomized control study if I did everything else? If I did blocking exercises, I'm doing SCAR mobilization, I'm doing this, I'm giving them a home program, and all these other variables that are out there, are they doing their home program? It's really challenging to research. Yeah. So but there are some studies out there with Ionto and its use for SCAR. But if you look at the number of patients that we use it for SCAR versus the number that we use it for inflammation, right? Huge variability.
You said that the patient gets the meds, do they bring their own potassium?
They could.
Okay, so it's not something that you would stop.
Well, it's all different. So like when I first started working, we would have a doctor who would be our medical director of our clinic. We would get a script for anything we wanted, potassium iodide, saline, dexamethasone, and we would just keep it in the clinic. The doctor would write the order, the referring physician would write the order, we would use our stockpile. When reimbursement has gotten crappier and crappier and crappier for these, and clinics don't want to buy the meds even, because even a bottle of potassium might be $18. You know, it's just one more expense. So typically now, you have to have a locked cabinet within your clinic. Has to be locked. The patient's name has to be on the medicine. And then I get a script for it from the doc. Patient goes to get it picked up. If you're in Grand Rapids, Keystone Pharmacy will mail it to you for $5, which is less than the gas it would take for anyone to drive there and back, you know. And then you just store the medicine for them and use their medicine for them. Because reimbursement is not very good to be able to. So probably each clinic will have their own policy, whether they have a stockpile and they use it for patients, or if they have their own patients. Yeah, I mean, if you look at a hospital, they have lots of options to fund the big picture, right? If you're a freestanding hand therapy clinic, that's all you got, right? You don't have x-ray and other diagnostic tests and other things that will help fund the bigger picture, right? But you're going to be doing not just this. You're going to be doing other things that you can bill for. Okay, so we talked about silicone gel sheeting, and this was brought up in our wound course on Saturday, where there's literature that supports the use of silicone gel sheeting. We're going to do scar mobilization, and then I showed you those elastomer molds. That's those blue tip molds. Like sometimes I'll use those for greater pressure on scar. Sometimes I'll start with the blue mold and then I'll move to silicone if the scar height has decreased. And then if I want to do dynamic splinting or static progressive, our main purpose is to put the tissue on a low load of force over a long period of time. And the TERT is total end range time. The number of minutes the patient can tolerate the tendon being lengthened, or the soft tissue, whatever the problem is. There's tons of research out on this, and there's tons of research out there supporting that this absolutely works. It absolutely works. So if your patient cannot move because of stiffness, not because of tendon glide, like Susie, can you attest to the difference? Sorry, I keep calling you out, but explain to the group what happened with your wrist extension.
So Nancy made me a wrist.
So how long have you been working on getting active wrist extension before this?
Well, I'm 12 weeks post-op.
12 weeks post-op, so you were probably held for 3-4 weeks?
3-4 weeks, then like the cast.
In the cast.
Splinting.
Right, so she's had 8 weeks of trying to get wrist extension.
Yeah, so Nancy made me a nighttime splint for extension, And she put it, I think I had 45 degrees of extension when we first began.
And this was last week, Thursday?
It was Wednesday.
Wednesday.
Yeah,
Okay.
so it's just been a week, and like, I've been wearing it every night, and I noticed like last night I could go way farther, so I brought it in today. And
So she put the splint on and she could create a gap
There's a huge
between
gap,
us-
yeah,
the
so it
splint
really
and where
did make a
it's at.
difference.
Did they measure it today?
They didn't measure it, but.
Okay, when you do the splint and you implemented this new thing, remeasure so you can show objectively, hey, I did this new intervention, I billed you for making this splint, and now I just gained 15 degrees of wrist extension.
We measured on Monday, and I only gained like 3 degrees extension, but I feel like it's so much more, so,
Mhm. Yeah,
yeah.
so we should measure that.
Mhm.
But we put her wrist extensors, something scar was blocking her from extending. We put it on a low load of force over a long period of time. We don't want her to wear the splint during the day because I want her to use her hand for function. But at nighttime, she's just sleeping. Put her in a splint. And what type of splinting is that?
Static progressive.
No? Serial static. I took a static splint and I'm serially adjusting it into wrist extension. It is a wrist cock-up splint, but I'm serially adjusting it. So I'm doing serial static splinting. And it makes a huge difference. My elbows that can't get all the way straight. If they're not straight, much better by the next visit. I'm making them a serial static splint. I'm putting them at their end range for an increased period of time with a low load of force over a longer period of time. And that will make the soft tissue lengthen in response to the need. So you have to do that. You could exercise every day for 20 visits and you're not going to get it if you're not improving quickly with exercise. You have to do splinting. That's why the PTs are never successful with hand patients unless they've had a strong mentorship from a CHT because they don't know how to splint. And your hand patients will never get it if you don't do splinting. They won't. You have to splint them. Don't be afraid to splint them. If you don't know how, call me. But first check their passive range of motion, or if I get to your clinic and they have full passive, you're gonna be in deep doo-doo for me, right? But you can call me and I'll help you. I just had a student texting me over the weekend about a splint she wanted to make. And I'm happy to help you, but don't be afraid to do it. You have to do it or your patient will not get better. Another option is casting or even Coban wrapping. You wanna get this total end range time. So if they can't get good flexion, you could wrap them with tape or Coban or something in a flexed position, put them in heat, put them in paraffin, leave them in the clinic for 20 minutes while you're working with somebody else. You know, they're just there hanging out, getting some turt, right? They're just there hanging out, and then you started your other patient, you're not billing for that time they're in wrapped. You might bill for the time that you put the wrap on, and then they're just hanging out, right? And then when they think they've had enough, you cut it off and they go on their way. Increase their total end range time. Another option is casting. But we'll look at this first. So here would be a dynamic splint for this patient. And do we think this is the best optimal position for her? Like, look at these bands, right? Do I like this? No. It'd be better off to move to a hook, right? Or a loop. Get her a loop to pull down, and then move to a hook when she gets more flexion and she can be in a better position. Or otherwise, I need to do an outrigger that will pull her out this way so she's not pulling on her fingertips, right? But here's a dynamic splint, okay? Look at her fingertips. Are they blanching? Yeah. Here's a cast. So, you know, like throughout my career, I've gone to some courses where I'm like, this was a really good course that I learned something that has changed how I treat patients, all right? My lymphedema course that I went to is one of those, right? That was a life-changing moment in my career, right? The other thing is when I went to Judith Coldit's casting course. right? So this is the old-fashioned plaster Paris